Hello, everybody. I was told if I don't start on time, we don't get lunch, so I will begin this. I'm Laura Shin. I'm actually the chair this year of the Foot Care Council for the American Diabetes Association. With me today is also Dr. Larry Lavery, who will be taking over after this scientific session. And I wanted to say thank you to Dr. Danny Fan, Kanika, Peter, JD, and Shelley for being a part of this group. We're very excited. We also have Dr. Singh with us, who will be helping with our scientific board in the future. So this is our Foot Care Leadership Group. We hope to continue this. We are actually very open to sort of expanding this. You'll see that this is a very multidisciplinary speaker session today, and we hope to continue that trend. I also wanted to say congratulations to Dr. Joseph Mills. The Pecoraro Award will be given today at 1:30, so there'll be a session with our different technologies, and so we'll all be able to congratulate him in person as well. Dr. Mills is a vascular surgeon at Baylor, and he has been really integral in publishing a lot of the work in limb salvage. Our nominations are open, so if you think of anyone that you know that has made a lot of impact in the world of diabetic amputations, amputation preventions, foot care, we'd really like your nominations. It would be great. And I have the honor of announcing our Early Career Abstract Award winner. Is Dr. Ganawan here today? We will be awarding her this award for the impact of 3-month continuous glucose monitoring program looking at diabetic wound healing, all within a safety net hospital. This is a very prestigious award. These are awards given to people early on in their careers to kind of help promote and foster. In this day and age, with all of the funding sort of challenges and the issues that we have, having as an association like the American Diabetes Association supporting these young clinicians has been really impactful, and so we hope to continue that. This is my plug, and also a thank you to all the staff and everyone that is here that makes this meeting happen, all the faculty that agree to come here to kind of put their lives on hold. The American Diabetes Association is actually one of the few international meetings that really encompasses all of the different multidisciplinary groups. And so to come together, create this brain trust of ideas is really incredible. So if you are able to, become a member, there's a lot of great resources that are available, not only to you and your practices, but also as a clinician, you can actually give those resources to your patients as well. So you have access to all of the latest and greatest research, technology, and we hope to continue that. So first up is Dr. Shai Rosen, who comes to us from Dallas. I'll start this right here. And he is a professor at the UT Southwestern in the Department of Plastic Surgery, and he's also the vice chair of research and development. Now, this is something that we really wanted to kind of touch upon, something that doesn't necessarily get addressed a lot, but looking at different types of options for our patients with diabetic neuropathy. I think a lot of us are sort of very familiar with the different medical management. We're looking at sort of alternative approaches. Again, this session is really designed to kind of stimulate conversations, but also to see that, there are other sort of alternatives out there. Dr. Rosen trained at Johns Hopkins University with a specialty in looking at peripheral nerve disease under Dr. Lee Dellen. He's participated in a lot of the sort of integral 10-year studies looking at nerve decompressions and will be presenting on some of that research today. We'll then also have Dr. Marcos Schechter, who studied in Brazil and is now an associate professor, is that correct? At the Grady Hospital at Emory, and his specialty is actually in infectious diseases. This talk always stimulates a lot of conversation because it goes beyond the antibiotics. What do you do? How do we treat these patients? Other alternatives for them. And then our last speaker will be Dr. Vlad Lushin from Wake Forest. We're very excited to have him. He's an associate professor actually in the Department of Plastic Surgery at Wake Forest. He studied in family medicine, but he has a focus on wound care and actually runs the wound care fellowship at Wake Forest. And so he has been an advocate both for the diabetic foot in many ways, looking at CMS codes, looking at different ways that we can really kind of push the envelope in terms of getting the attention and the reimbursement for diabetic foot. So with that, Dr. Rosen.
Thank you, Laura, and thank you everybody for being here. I was asked to start with a slide. Let me see. Do I just do the arrows here, or okay, I'll just go here. Okay. To disclose, so I have nothing to disclose, but as was said here, I am actually a plastic surgeon. I'm not an endocrinologist, and I deal with a lot of nerve issues. Probably one of the main issues that I deal with is treatment of facial palsy. But early on in my career, one of my mentors was Lee Dellin, and he had asked me to talk to several of his patients that underwent decompression with painful diabetic neuropathy, and I did. And I was actually quite intrigued by the answers. They were quite impressive. And then he asked me, hey, well, maybe you can design some study to see the effect of nerve decompression, but do it better than I did. Very naively, I said yes. I thought, man, that's going to be pretty easy. And the reason he asked me that is because up to that point, everything was considered level U evidence, meaning there's surgeon bias, non-prospective studies, non-blinded, they're not controlled, meaning a lot of study design flaws. The American Association of Neurology recommendations for future research, this is a 2006 paper, said again at the same points, we need more randomized controlled trials, preferably blinded. You need to show monitoring of glycemic control and detailed reporting on postoperative complications. The motivation for me was, well, first of all, I was a junior faculty and I had not much to do. I didn't have a lot of patients to operate on yet. And plus, as a plastic surgeon, we might affect 7,000, 10,000 patients during our career, but certainly this is an opportunity to maybe affect a few more patients than that. So I said, okay, let's take it on. The other considerations that I said is, well, pioneers like Lee Dellin took all the arrows. I'm just going to sweep in as a settler and take the land, and that's all easy. Certainly, I was quite mistaken about that. I had no idea what it was to do in RCT, how expensive, how time-consuming it is, and how difficult sometimes it is, especially if you're planning on a sham surgery, to put this through an IRB. So we went ahead and designed this study. It's got a long name, but basically we called it DNND, the Diabetes Nerve Decompression Study. And I put one in because I'm going to also report 10-year follow-ups in the DNND2 study. The primary goals were to examine the effect of nerve decompression in patients with painful diabetic neuropathy that resisted medical treatment for a year. And we just wanted to evaluate pain and quality of life. So the study design is as follows. We had 3 screening phases. The third screening phase was with our neurology group, very independent screening, and then patients were enrolled. They were randomized into a surgical group and into a control group or an observation group. The surgical group was further randomized into one extremity that was decompressed and the other one which had sham surgery. We initially planned a 1-year follow-up, and I had read several articles in the New England and Lancet, 6 months follow-ups, 12 months follow-ups. I thought, wow, okay, that doesn't sound long, but that's what we did. Luckily, we had a very slow recruitment. It's very difficult to recruit into these studies. And we had a 5-year recruitment. So during that period, exactly the same criteria that we had were remaining for 5 years, and the follow-ups were about 56 months, close to 5 years, under the original scenario of the criteria that we had. So we evaluated about 3,000 patients. We ended up enrolling 92 in the surgical group, and the control group, 46 patients. Subsequently, after the third screening phase, which is neurology, we ended up with 40 in the intention to treat group, in the surgical group, and 37 in the control group or observation group. Long-term follow-ups were 36, a 5-year follow-ups 36, and 14. I did a mistake as a junior investigator. We only called up the patients that were in the per protocol analysis group. I should have called the intention to treat group as well, and we did that actually in the DNND2. Randomization helps, and this is how it helps. When we looked at the baseline characteristics of both groups, all of these variables, there was no significant difference between the intervention group, meaning the surgical group, and the observation group. So randomization did help the statistics. Exclusions of the first 12 months were very similar between groups. When we looked at the 56 months We did have 6 deaths in the control group, not so much in the intervention group. We tried very hard to track these etiologies down of the deaths. We could not do that. Hemoglobin A1C exposure during the entire trial was similar between both groups, and we made sure we had that recorded. And pain results at 12 months, there was a very significant difference between the surgical group, which is down here, and the observation group. But when you looked at the decompressed extremity versus the sham extremity at 12 months, there was no differences. And that brings about the question of placebo, of course. Quality of life, there were differences, significant differences at 12 months. But when we looked at the 56 months results, this is very interesting. Again, the surgery versus a control group, significant differences in pain, meaning after almost 5 years, the decompressed extremities were reported to have significantly less pain than in the control group that had no procedures. But at that point also, we saw a significant difference between the sham leg and the decompressed leg in terms of the pain. I want to touch on the DND2 data as a continuation of this, and we evaluated pain at 10 years. We did some electrodiagnostic and sensory testing at that time as well. Over here, we had 28 patients in the surgical group and 21 patients in the control group. We did call the intention to treat patients. And again, this is not under the original criteria of the study. Data was exposed at this point. Examiners were not blinded, but the patients were still blinded. Patients did not know which extremity was decompressed, which was a sham extremity. Hemoglobin A1Cs similarly were similar in both groups up to 10 years. The pain scores, very similar. There were no changes, meaning in the observation group, the pain did not change. It was still high versus the intervention group and the sham, meaning the sham extremity and the decompressed, no changes in pain. When we looked at sham extremity versus the decompressed extremity, that gap or the significant difference was maintained at 10 years. We looked at tibial motor amplitudes. Only the decompressed extremities actually showed some recovery. None was observed in the sham extremity. We looked at tibial motor latencies. Again, only the decompressed extremities demonstrated some improvement. None were seen in the sham, and none were seen in the control extremities. We looked at vibration. Again, the surgical extremities showed at least preservation, while all other extremities, sham and controls, worsened over the 10-year period. So we saw 10-year preservation of pain improvement. The differences between the decompressed and the sham were still preserved at 10 years. Nerve conduction studies showed some improvement, or at least preservation of axons in the decompressed, but this is not the case in the other extremities. So the main question, of course, is this a placebo effect? Now, I had a dream. This ended up to be a much longer study than I thought. I thought it would take me 2 years, 3 years. It took us nearly 8 or 9 years. I thought we would get this published in one of these journals. And really the first time, I always remember what Michael DeBakey said. He's a cardiac surgeon, was a cardiac surgeon at Houston. He says, one of the things that we do the least is sit down with ourselves without interruption of beepers, without interruption of phones, just sit and think. And COVID actually provided me that period to actually sit down and write this. Of course, not all dreams come true. We were rejected from New England in the pre-review process. Similarly in Lancet, I had to go to a lot of seminars during COVID dealing with rejection. And JAMA gave some very interesting commentaries. First of all, the reviewers acknowledged that this is an extraordinarily controversial subject, and I knew that ahead of time that we were really working against some big forces. I'd say potentially some biases also within certain communities of endocrinology and neurology. But some of the comments were interesting to see. One of the commenters said, well, did you see compression in these surgeries? Well, that wasn't the question, actually. The question was the interpretation of how patients responded to pain. And whoever's done these surgeries, you can't always see compression. So this would be a very subjective, actually, variable to look at, and I was surprised that we got a comment on that. And there was a concern about unblinding, meaning would the patients feel a difference between an incision in the leg and actually an incision and decompression on the other? I think it's a legitimate statement. A lot of RCTs today do ask the patients along the study what they think on the side. The only issue with that is what do you do when patients will tell you, well, we think that this extremity is a lot better than that, and you have a 90% compatibility, then people could say, well, the patients are not blinded. So we very deliberately did not ask patients in the middle, because when you do these RCTs, you will be surprised how patients are very sophisticated at trying to find out what extremity was actually operated. They'll go to other physicians in the system. They'll tell them to plug into Epic, see things that they're not supposed to. So we very deliberately didn't do that as not to get their attention. But one of the commenters said that, well, our surgical non-control group is not a good comparison because no procedure was done there. And he said, well, you did a good job at doing a control group within the patients, but I don't think that's optimal doing it within the same patients. You should have done it in other patients. Now, we very deliberately did it within the same group of patients or within one individual patient, because that can account for sex, that can account for culture, that can account for genetics, variations that are otherwise difficult to account for. And what they were suggesting is do a third arm here of only sham surgery. Now, I can tell you we had thought about that. No IRB in the world would approve an incision on a diabetic foot, putting somebody for an hour and a half under anesthesia just for that. You have to show an IRB some benefit, potential benefit to the patients, not only to medicine, but to the patients themselves. So these are a bit frustrating comments to get when you put so much work into something that obviously it's not a perfect RCT, but I don't think there is one out there. Subsequently, we got into Annals of Surgery. At least that's the most cited surgical journal that we have. And really the points of discussion, if any one of you are writing papers and if you're citing and you cite this, then I think the most important things to think about is, well, okay, we have patients 10 years later showing significantly improved reduction in pain compared to an observation group. The observation group was chosen, why? Well, because it shows the natural history of the disease and also accounts for regression to the means, meaning there are some improvements, but subsequently they will regress to the means, and we have a good comparison to that. There was a reduction in opioids in these patients, near significance. It wasn't significant. And probably most importantly, we see clinically, and there's a lot of basic science on this, on descending pain control pathways, meaning mirroring of pain. We see this both when we create pain on one extremity, how it affects another extremity, and we see this with reduction in pain on one extremity. We see this in the other extremity. There's a 2014 study on diabetic nerve decompression from the Netherlands, who patients actually knew one side was decompressed and the other was not. They knew it, and they still reported reduction on the contralateral side, albeit less than on the decompressed side. So hopefully for the future, there's going to be more research, both clinical. Hopefully some of the people here will take that on, and certainly I hope more in the basic science research, and hopefully more open minds. We were talking before the session. I hope that, I don't know how many endocrinologists are in this audience, but it would be nice to go against an audience that's a bit more resistant rather than perhaps in agreement. And the story, I really recommend reading this book, The Butchering Art. It's about Joseph Lister, and he asked one of his professors, he said, look, my career is almost done. I keep on telling people that this purulent drainage and this foul smelling is not a good thing, even though during the Victorian era, that was considered a good thing in healing. He said, well, you're doing one big mistake. You're trying to teach the old guard about this. Start going only to the universities in Europe where you have only students, younger people with open minds, talk to them. And then, obviously, all the rest was history. So I want to thank you again for the opportunity to give this talk, and obviously we'll take questions afterwards. Thank you.
Hello, good morning. So my name is Marcos. I'm coming to you from Atlanta, Georgia, Emory University, and these are my disclosures. How do I advance this thing? All right, so today I have the pleasure of talking about bugs and drugs, antimicrobial strategies to avoid amputation, title given to me by Laura and friends. So I have pretty much two goals today. For the first half of the talk, I'm going to talk about established technologies, things that I think everybody who takes care of people with foot ulcers should know. And then for the second half, I'm going to talk to you about selected recent clinical trials or ones that are under the way that I think will change how we do things in 5 years from now or so. So, seems obvious, but the first thing we should know is how to diagnose and stage a foot ulcer infection, right? In fact, the recommendation how to do that is the very first thing that the guidelines point out. These are the 2023 joint guidelines between the International Working Group on Diabetic Foot, IDSA, Infectious Disease Society of America, and others. So what are these criteria? Well, you have to have two or more of the following: either local swelling and duration, erythema, at least half centimeter from the wound, tenderness, pain, warmth, or purulent drainage. If you have two more of these, that's a foot ulcer infection. How do you stage it? If the foot is infected and the patient is septic, severe infection. If they're not septic, but there's a lot of erythema, or the infection is deeper than skin soft tissue, be it an abscess, be osteomyelitis, that's moderate. And if none of that is present, that's a mild infection. Well, why does that matter? It matters because this scheme, Lavery, who's around there, validated this in 2007. And when you follow patients over time, this correlates with hospitalization in black bars and amputations in gray bars. It also gives you a hint of what antimicrobials will be helpful in this case. In the US, the vast majority of mild infections are gram-positives only, staph, strep. Once you put in the moderates, now you have some gram-negatives, and once it's severe, then everybody's there. Gram-positives, gram-negatives, and anaerobes. It also tells you how fast you need to start antimicrobials and who to call. For a severe infection, you really want to start things right away, but also you want to call your surgical colleagues because at that point, an amputation could be necessary to save somebody's life because they could be septic from that limb. When thinking of infection, you really have to think of ischemia because these two act together for bad outcomes. So Urodile is a classic study from 10 years ago in Europe where they followed people, about 1,000 people over time. And what they found is that the odds of non-healing were really dominated by interactions between ischemia and infection. So it's pretty intuitive, right? If blood is not getting to the wound, it's not going to heal. And also that vancomycin that you give to the patient is going to get everywhere to their body except to the foot. It also turns out that evaluating ischemia is not as easy, as straightforward as most think. ABIs are not adequate in this patient population. You really want to be working with your vascular lab. Talk to your surgeon about toe pressures, transcutaneous pressure, skin perfusion pressure, and so goes on. So this is key. If you're talking about infection, you need to think about ischemia. Infectious disease doctors, we're boring. We want cultures, right? We don't want to just give antibiotics. We want to guide them to something. So what culture should you collect? Should you just swab that wound? Well, that's a possibility, but the guidelines, based on data, prefer that you do tissue biopsy if you can. If you can't, cleaning that wound and doing swab by the Levine technique is okay too. If the patient has osteomyelitis, what you really want is a bone sample, either in the operating room or percutaneously. Why is that? That's because soft tissue samples and bone samples, their cultures have very poor correlation. So this is a meta-analysis we've done a few years ago. Every row is a study. You can see the correlations between bone and swab or tissue needle puncture. And you see that the rates of identical cultures are very, very low, as low as 3% and maybe highest is 32%. One canonical and wrong ID teaching is that if there's Staph aureus in the tissue, in the soft tissue, it has to be in the bone. That is not true. So here you see that the rates are 43 to 83%. And that's why we say that if you want to know what's in the bone, you need bone samples, not tissue samples. Another ID myth, the idea that inherently antibiotics are, if given IV, are better than PO. Where does that myth come from? It comes from 3 papers, case series published in the England Journal into 1970s, where these guys got together, looked at their patients, and said this: in our experience, key here, in our experience, clinically recurrent osteomyelitis is never controlled or rarely controlled without debridement and 4 to 6 weeks of IV antibiotics. I think they would give this level of evidence U nowadays. So here comes the OVIVA trial. So this is a large randomized controlled trial a few years ago where they randomized people to PO or IV. You're eligible if the attending thought that you would need 6 weeks of IV antibiotics. It's a non-inferiority design. And this is the key thing. In the worst case sensitivity analysis, everybody on oral who had a missing outcome, they said you had a bad outcome. Everybody on IV who had a missing outcome, you said had a good outcome. Even with this completely rigged analysis, oral was non-inferior to IV. Now, of course, this trial has limitations. Very few patients in OVIVA had foot infections, and we don't know how many had diabetic foot ulcer infections. I don't think all bones are created equal. I don't think we quite understand what's the difference between different bones, but I think it's intuitive that calcaneal osseous is different than toe, and toe is probably different than the spine. This trial was also not designed to compare different classes of oral antimicrobials, right? And it's also intuitive that they're not all created equal. The other thing OVIVA reminds us is that we really underestimate the complication rates from PICCs, right? Those IVs that we put on people to go home on OPAT. In OVIVA, almost 1 in 10 patients had a central line complication, ranging from clots to infections and bacteremias. Patients hate having PICCs in their arms. They have limitations in lifting weight. If you had kids at home, that's impossible. If you do any work outside, forget about it. And I had a PICC meeting with Grady Leadership in 2018. When I came back, a patient had left a PICC at my office doorsteps to remind me why they don't like it. So this is from front of my office. The other thing that we talk a lot about that I think is a little bit of a myth is that everybody with foot osteomyelitis needs surgery. Many do, but perhaps many don't. So this is a systematic review. And what you can see here are remission rates of people treated medically. And of course, this is not comparative. This is very low level evidence. But what you can see here is that remission rates seem acceptable. To my knowledge, there's only one RCT. The rates of remission were similar, very, very underpowered. But one thing we need to keep in mind when we advocate for amputations is talking to people who understand the biomechanics of that foot and be like, are we creating a new problem here, right? Is this what the patient needs? So really working with your surgeons to understand the biomechanics and what's for the future of that patient are needed. So for the first time this last year, the guidelines say that medical therapy without surgery is okay for people with forefoot osteo without exposed bone, immediate need of an IND or don't have PAD. So this is the first half of my talk where I think these are the basics. Know how to diagnose a soft tissue ulcer infection based on guidelines. Think about ischemia. Soft tissue cultures do not represent what's in the bone. On average, oral is better than IV because there is no PICCs and it's cheaper, and surgery is not mandatory for a diabetic foot osteo. In the second half here, I'm going to talk about some recent developments, things that I think are interesting and are going to change the field moving forward. So in ID, we're really concerned that we over-treat our patients with longer than needed antibiotics, and there's mantra of shorter is better. So this group did a pilot randomized controlled trial of 3 versus 6 weeks of antibiotics for people with residual osteomyelitis of the foot. So I had osteo of my toe, Laura took me to the OR, left a little bone infected there, I get 3 or 6 weeks. Very generous non-inferiority margin at 25%. And in this small trial, with 93 participants, outcomes were similar. This same group did a clinical trial of 10 versus 20 days for patients with moderate to severe soft tissue infections after debridement. Again, non-inferiority margin of 25%. Small trial, but similar. This is a really cool group. They're doing important work. There are ongoing confirmatory trials. I am looking forward to see what this shows, to see if this can definitely change our management. Shorter is better for the most part, but sometimes we get burned. Recently, we learned in prosthetic joint infections, a trial of 6 versus 12 weeks. 6 was not inferior to 12 weeks. So I really think we need to keep an eye out for evidence with non-inferiority margins that we believe in. Percutaneous bone biopsy. So this is a group from France that what they did is trained a guy like me, who is not a radiologist, not a surgeon, to do bone biopsies at bedside. And what they find is that somebody like me can do a bedside bone biopsy and have similar safety and efficacy compared to a surgeon or radiologist. Now, what I find coolest about this paper is that the patients who had a culture positive and were treated with antibiotics and those who are culture negative and treated without antibiotics had similar healing rates. In other words, you could get somebody like me, think somebody has osteo, do a biopsy successfully, and if it's negative, not give antibiotics, say this is not osteo, this is something else, and have good healing rates. So this is, I think, could be practice changing if we start training on this. Now, we don't know if percutaneous bone biopsies improve outcomes, and that's the aptly named BBOP trial. is coming up, right? Because I told you soft tissue and bone don't correlate the cultures, but we don't know if having bone improves outcomes. And this is what this trial is setting out to respond. Long-acting glycopeptides. What is that? Think of vancomycin with a half-life of weeks, something that you could give with much less frequently. So those are daptomycin and erythromycin. So this RCT, and I put lots of quotes here on the word RCT because it's randomized 7-to-1. So 60 participants got dalbavancin on days 1 and 8. 10 participants got their IV antibiotics for 4 to 6 weeks. They had similar cure rates at day 42. This is bone and joint infections, NOS. So I think my fear with these drugs is that we start using them because they're IV and go back to the myth of IV is better than PO. But in my practice, I've had patients who can't tolerate orals. The person has a kid at home, won't have a PIC. This is a great drug for somebody like that. Rifampin. So part of the challenge curing bone and joint infections is biofilm, right? These bugs set biofilm in bone. They're not replicating. It's hard to kill them. So rifampin is an antibiotic that has that property. So this is an observational study from the VA where they compared 6,000 people who received rifampin to 130 that didn't. The people who did not receive rifampin were older and had more comorbidities and also had a higher amputation or death rate compared to those on rifampin. And that's what led to the ongoing VA Intrepid trial where they're randomizing people to rifampin or no rifampin. Enrollment is slow because rifampin has a lot of drug-drug interactions. That's a problem. I really wish they had tried rifabutin and another rifamycin with less DDIs, but that should be coming in the next year or two. Local antibiotic delivery. I love this idea. So I get an amputation. There's a bone cavity there. Instead of getting a bunch of antibiotics, Laura can make some antibiotic cement, put it in there, and then you have very high concentration of antimicrobials there. To my knowledge, and I think to Lauren's knowledge too, there's only one RCT. It's pretty small. It's methodologically incredibly problematic, but they saw a larger wound reduction in the antibiotic-loaded cement. This is a trial that's coming out soon. It's finished. Everybody in this trial got antibiotic cement and was randomized to either a short course of systemic antimicrobials or a traditional course, and the press release says it was non-inferior. I can't wait to read this. This could really be practicing changing. This is not necessarily foot infections per se. This is the MolecuLight device. It's a device where you can use fluorescence to see if there are wound bacteria biofilm in the wound area. So in this clinical trial, patients with uninfected foot ulcers were randomized to standard of care versus the MolecuLight. People in the MolecuLight, they got more aggressive debridements because presumably the wound care folks saw the biofilm there and tried to take it out. They had higher healing rates. Again, small trial. I'm interested to see where this technology goes moving forward. And there's so much more, right? Things I couldn't talk to you about today. So there are ongoing trials of phage for diabetic foot osteomyelitis. There are novel forms of linazolid without less neuropathy and cytopenias. There are novel topical antimicrobials. But I really want to bring us back to, I think, a remarkable sentence from the 2012 IDSA guidelines that I think still holds true. The main problem currently is less our lack of full understanding of the problem as our failure to apply what we know works, right? So I think everybody here sees their patients going home, leaving the hospital with the same shoe they came in, right? Leaving the hospital and not knowing how to take their insulin, and so goes on. So I think there is a lot that we're going to learn in the next years that might improve outcomes, but ultimately, if we can't implement the science that we discover, we're going to be in the same place. To that end, our group a year or two ago wrote a state-of-the-art review at CID talking about comprehensive approach of diabetic foot infections, where we give some ideas of how to improve care for patients who have barriers to care. So I finished 1 minute earlier. That's just great, and thanks for having me here.
Hey, I'm Dr. Vlad. I thank you for the opportunity to present. I'm like to present about AI to reduce risks at home, specifically for diabetic foot ulcers. And I will admit from the get-go, I don't know too much about this, but I used the challenge for this talk to educate myself about it as well. Probably doesn't include everything that should be included in this talk, because we are in a time and age with whatever you publish today, it's already obsolete, and there's some new technologies and some new findings around the corner. But I'll try to kind of give you an idea. I am by training a family doctor, but I am a faculty in a plastic surgery department at Wake Forest. And I see about 400 to 600 patients every week. About 150 to 200 of those are diabetics over the past 13 years. So I'm kind of like trained on the job. And we open up a fellowship at our institution because I think that the practitioners who do wound care in outpatient settings, they need to have a lot more training. This is a 1-year fellowship, as the current standard is like 1 week training for wound care clinicians. I think that's a whole different talk. I'm involved with a number of other organizations there trying to promote the clinical practice of our field. I do work with some companies out there, and if you want to take pictures, feel free to do so. So I will talk a little bit about a historical perspective on diabetic foot ulcers. I will mention some loss of protective sensation, some neuropathy, and then I'll talk about some AI home monitoring tools as well. So has anybody heard about Dr. Jocelyn? The original endocrinologist, okay? You know, this is a paper that he's published 1934. And so he's talking about the diabetic gangrene has been an increasing menace to my patients. It's an absolutely fascinating paper. He mentions here how gangrene has risen, but the coma has fallen. Great numbers here. I will not go over these numbers as well. It's a fascinating paper to read, but I just kind of want to point out there that this is a problem that we've known for a long time. If you have a chance to read this, please do so. He actually went and put a lot of thought into this. He described the etiologies of these problems, including atherosclerosis, infection, delay in treatment, poor diabetes control, trauma. He didn't mention neuropathy. I think that's part of the reason that we're still struggling to understand this condition, and there's maybe lack of focus on the neuropathy as a whole. And this is still this is impacting our care to our patients that we provide these days. And so he described the medical treatment troika, okay? So diet, exercise, insulin, multiple small doses. He actually identified that this is a preventable disease, and he talked about strategy to prevent this. He described the multidisciplinary approach. He described the team of people that is necessary to be involved for treatment of diabetic foot ulcer patients. So my question is, what has changed? We're still struggling with the same things from 90 years ago. Okay, there's a lot of great institutions where great teams have been established, but we're still struggling. Like my previous speaker, there's things that we know how to do, but we're struggling to implement them. We're struggling to implement what we know it works. Okay, so are we better at treating diabetes? Are we better at preventing the diabetes complications? If we look at these predictions. In this latest edition of the Diabetes Atlas from 2025, we better get our ducks in a row real fast, because this is going to be an ongoing problem, so it warrants more attention. We'll talk about some U.S. data. It's an alarming number of patients with diabetic foot ulcer, and this is a significantly increasing cost. We're talking about billions already. The really interesting part from some of these papers presented here, there's a lot of this cost, it is now accruing in outpatient setting. You think about the cost in inpatient setting, but a lot of the therapies for diabetic foot ulcer now are being shifted into the outpatient setting. So the diabetic foot ulcers, it should warrant a really stark prognostic, because the mortality rates and the complications that these drive, including infections, amputation, hospitalization, the cardiovascular burden, and this all goes to the clinical underutilization. It's the same idea. There's things that we know how to do, but we're having trouble to put them into practice. And there's papers after papers that look at and point out these numbers. 2004, the left far, 2007, the one on the right. The latest one, 220, is below. And so you can see that patients with diabetic foot ulcer have the same mortality as all cancer. Patients that have PAD or amputation have much worse mortality rate. Those bars there on the right. It is better off to have breast cancer. It is better to have prostate cancer. It is better to have those cancers than to have diabetic foot ulcers. So these patients are sick and they're dying. Okay, having such a bad disease, it doesn't even have an ICD-10 code. So I am part of a WCCC community, Wound Care Collaborative Community. This is mandated by the FDA and by the regulators, and it's sort of a way to tell our field to kind of get your ducks in a row, get your stuff together. And so that's what we're trying to do. And for the purpose of understanding these conditions, one of the effort that we have is to create this ICD-10 code. This project is underway. If things go the way we hopeful, next year in June, we're going to have a DFU ICD-10 code. So a little more data about diabetic foot ulcers. These numbers are kind of brutal. Amputation every 20 seconds, a new diagnosis of diabetic foot ulcer every 1.2 seconds. And it's estimated out of 18.6 million diabetic foot ulcers in the United States, about 1.6 have a diabetic foot ulcer. 17.5 billion to the healthcare cost. And one of the things that we know it needs to be done to improve the care for diabetic foot ulcers is the mechanical offloading is the holy grail, and we're struggling with that. This is a paper that is an excellent review of this condition, and it has really good graphics showing how because of the loss of protective sensations, patients walk on their wounds. So the main challenge with diabetic foot ulcers is not necessarily how to treat it, but how to stop the injury. So I do have a personal checklist when I see a patient with diabetic foot ulcers. I think about neuropathy, ischemia, cellular failure due to high blood sugars. Do we have adequate nutrition? Are we treating an infection or so? But over and over, like probably 85–90% of times when a diabetic foot ulcer doesn't heal is because of the number one issue. So I put a couple of slides about this loss of protective sensation. This is sort of like the opposite of the painful neuropathy. Painful neuropathy, aching, burning, flushing, blood flow, skin changes, that typically tends to draw attention. But after this phase passes, in a few years, 10, 15 years into diabetes history of a patient, then things go numb, things go silent. And patients don't feel that the shoes are rubbing, and so they don't feel that they walk on the wounds. A lot of times they come out, I saw blood on my kitchen floor. Where's the blood coming from? Oh, it's from my foot. Or something sticks. I don't know what stinks in the house. Like, what's stinking? Oh, my foot is stinking. So I've seen this story over and over again. And this neuropathy, we don't really understand it. There's glycation and damage and swelling, and probably the chronic swelling and decompression actually helps. But this cycle, when a patient's lost that feedback, it's allowing the injury to happen. So no matter how we treat it, we're not making progress with it, and that creates this ulceration. And this is also the explanation for the very, very high chance of recurrence for the diabetic foot ulcers. I don't think that we have a good way, and I think providers, we don't understand this cycle. And one of the things that actually helped me understand this is actually a medical book, Dr. Paul Brand. He's the one that described the nerve damages done by leprosy, by Hansen disease. And he's the one that received a grant in his late years at Carval, Tennessee in the 80s to create a synthetic nervous system. I think it's probably one of the first things that, it wasn't AI, but they were trying to create a synthetic nervous systems. And it failed because of very, very poor acceptance. So because of this neuropathy, there's campaigns like this one that show your toes. When you see patients with diabetic patients in your clinic, ask them to take their shoes, ask them to take their socks off, and look at their feet. And the typical difference between social media and reality, okay, this is what patients are hiding. They don't want you to see this. They're ashamed of these things. But I've heard this over and over again. It's just a toe. It's just a toe. No, it's not just a toe. A toe is another toe, and this little piggy, and it's transmit, and it's just a snowballing effect that happens on, and patients end up with amputations, which are disastrous. So there's this huge gap in what we know what to do. For example, international work on group on diabetic foot ulcer, they strongly recommend offloading, total contact casting, non-removable knee-high devices, and papers studies that adoption about 2%. Okay, so more than 50% of patients that should receive offloading, they don't. So there is this huge implementation gap with a number of reasons for cited as barrier to these adoptions. So this is where we come to home-based monitoring. As a clinician, like I said, I don't understand this neuropathy, but as a clinician, this is what I hope to get out of this home-based AI monitoring. I hope that some kind of a tool will help us monitor the health of these feet, and they are going to be user-friendly devices that patients can get into a routine, and this integrates with our system and draws our attention when needed, not when the foot is stinking and is bleeding on the floor and you don't know what to do with it. So I'm going to spotlight a couple of these technologies. Like I said, I think this list is incomplete, but it's just sort of to give you an idea of about what's going out there. There's a number of smart footwear sensors that are aiming to transform the way we monitor these patients. There's a increase in remonitoring home monitoring codes, and that's got actually payment by the payers in the past few years. So this is a daily thermal imaging mat. The idea is that a foot and an area of a foot, it heats up before it breaks down. So an area of the foot, like the first NT or lateral foot, or one of these areas that is prone to stress, it will increase its temperatures. And this company has data that they can predict up to 5 weeks before the area breaks down. So if you get the patients to come in the morning, put their socks, just put their feet on the mat, it measures the temperatures and it kind of collects this data. And when a trend is seen and it's going up in the temperature, that triggers a communication to the providers, get them in, take a look, assess their orthotics, etc. Okay. Similar technologies, but in socks. There's a number of attempts out there to make socks with temperature monitoring, and there's even hardware like scanners, like a device looks like an iPad, and infrared-based technologies, kind of like temperature monitoring. You just put your feet on this pad, FITSI, and then take a picture of it, and this keeps track of these temperatures. So these are thermal monitoring technologies. Very simple ideas, but sort of like different ways to use it. As far as I know, none of these has gained wide traction to clinical practice. These insoles, beside temperature, they also have pressure monitoring as well. So patients can use them, put them in their shoes, and you probably have a layer under this pressure mapping that you can adjust to adapt to the patient's feet to decrease the pressures on the temperatures in those spots. And this is one technology that I've partially adopted. This is actually used for treatment. It's not just for prevention. You have a patient with a diabetic foot ulcer. One of the major barriers to adoption is patients perceiving of being sick when they have a cast on their foot. So Foot Defender is an attempt to make a device that is acceptable. They use a Nike designer to create this, so it doesn't look like patients are sick with it. And it's a really good offloading device, and it works almost as good as a total contact cast. But when this is coupled with a device that it's called Sensoria Core, is this little blip in the front of the cast. And so that's got accelerometer, it measures the steps. So this device knows whether patients are using the boot or not. And the patients have a watch on their wrist, and they get reminders like, did you take your boot off? Why did you take it? Put it on. And so, are you okay? This device actually knows whether the patient are using it, so they're prompting them to use it all the time. And this feedback is also sent to the clinician dashboard. So there's studies ongoing. I think some of them are going at Keck Medicine that actually shows even better outcomes in healing diabetic foot ulcer than total contact cast. So this is very, very exciting to see. And so in conclusion, we're trying to shift to proactive care where we get these tools the patient can use and then it integrates with our systems and get those patients in when we need them. So I would ask you to remind your patients to take your shoes and socks off. I have seen much better outcomes in patients that have CGM. They heal better when their sugars are better. And so please pay more attention to patients who have diabetic foot ulcers. They need more intense care to try to prevent the terrible amputations. These are some of the references I used. And if anybody is interested to get full one-year education taking care of patients with chronic wounds, please reach out to us. Thank you.
All right, I'll invite all the speakers up and we can take some questions. Actually, my first question is for you, Marcos. When you have a patient that's on dialysis, and let's say there are some easier ways to just sort of coordinate that with antibiotics, do you see a difference between oral antibiotics and versus like patients that are getting it through dialysis through their dialysis centers?
Yeah, I don't have numbers to tell you. What I do know is that a lot of times there is failure of coordination with the dialysis centers to give the antibiotics at dialysis. And we've actually had in other disease processes some really, really negative outcomes. I had a patient with end-stage renal disease, Staph aureus bacteremia, who the dialysis center did not give the order for vancomycin, and he came back paralyzed from lumbar infection. So you really need, that's a care coordination that needs to be done very carefully. But to the point for the other audience, there are a lot of antibiotics that can be given after dialysis IV, and the pharmacokinetics allow for that, and that's a perfectly good situation to give somebody an antibiotic.
Question?
Hello, Stephen Twigg from Sydney, Australia. I'm an endocrinologist. Addressing Dr. Rosen. Dr. Rosen, if I was managing a patient who I was concerned had an upper limb, say neuropathy, carpal tunnel, I'd certainly get nerve conduction studies done beforehand before supporting them in a rationale to decompress. And we know that early decompression in median nerve compression can be very effective. But following that parallel in the lower limb then, can you comment on the rationale with decompression? And if it is demonstration of some form of nerve conduction block related to some form of compressive neuropathy, then shouldn't that be demonstrated first before attempts at decompression?
So, yeah, it's an excellent question. And by the way, I didn't show you the data here, but we did actually do nerve conduction studies on all of these patients. I think, as you probably know, the literature, electrical diagnostic studies have been very difficult in terms of reliability in the setting of diabetes and diabetic neuropathy in the lower extremity. Very low yield from that perspective, as opposed to upper extremity carpal tunnel. So I think we should probably look at other modalities other than NCSs, maybe MRIs, maybe ultrasound, to potentially create some kind of a preoperative validation system for compression. And that'll go into a very different set of studies is what is the sensitivity and specificity of those? You really have to make sure that you have that. Which is very difficult. Like I said, you can open these and you won't visualize on the macroscopic level these differences. And perhaps in some of them, it's not on the macroscopic level. Perhaps it is, as has been alluded to, ischemia. So it's things that you may not be even able to identify with those modalities. But I'm sure in today's world, you could, functional studies, et cetera, maybe a combination of them. To use them as sort of radiologic biomarkers. So anything that could help with a pre-diagnosis, yeah, of course.
Thank you. And a brief follow-up. Were you confident then you could recognize compression? I know a lot of patients were excluded from one arm of the study. So with your decompression, were you confident that you could identify compression prior to the surgical procedure?
So we used several, we used NCSs, we used other sensory studies, we used Tinel sign, et cetera, which is not acceptable on all as a sign. We used everything that was available at the time
Yes.
to use it. We did not, for example, use an ultrasound that maybe could have helped. Maybe. There's not enough studies to show that, to demonstrate that. But I think what we did do here is we took two very similar groups of patients. And that is something that's key here. Maybe we don't have all the tools to assess them preoperatively, but the groups were very similar. And with the tools that we had, all of them had this, based on the tools that we had some degree of compression based on the combination of the tools that we had. You may accept them or may not, but they're exactly the same patients. They were exactly similar from a pain perspective. You saw the table,
Yep.
the baseline.
Yep.
So you decompress them, and that's the one factor. So you may not have all the tools ahead of time, but you have one intervention that one group had and one did not, and you saw a difference. So of course, do we need more work on this? No question about it.
Thank you.
Yep.
Thank you. My name is Dr. Mahmood. I'm from Pakistan. One of the concerns in working from the underdeveloped countries is basically the education of the patients. And what we see normally, the patients who have either a good control or a bad control, but on the top of that, they are smokers. And you ask them that how long you've been smoking, and they will say, well, I've been smoking for 20 years, and how much you've been smoking? 20 cigarettes a day. My question is, if at any stage, when they develop the foot ulcer, by stopping the smoking, which should be, how long would it take really to have some sort of a clinical effect when they stop smoking? Would it be maybe in 24 hours, weeks, or months? Do we have any data to suggest that?
I think there's some studies out there, I can't remember them right now, where it shows that you see close to normal microcirculation after 21 days of zero nicotine. That's what I tell my patients. I usually tell them for wound healing, you need to make new blood vessels and you need to deposit collagen. And nicotine is a vasoconstrictor, so it doesn't allow you to develop those small blood vessels. And you try to heal a wound while you smoke is like you're trying to run your car with the parking brake pulled.
Right.
So you can move your car, but you're not going to get too far away. So, and then we have patients like, I only smoke a cigarette a day. Well, this 1 or 2 cigarettes a day sort of maintains this vasoconstriction circle. It's kind of like you just keeps it going. So I think there's a paper out there if it's 21 days, so 3 weeks after you see sort of like return to baseline microcirculation. And then I think it depends on the length of time that you smoke. So.
I agree with that, because what I tell them is to stop it immediately and then wait and see how long does it take. But practically looking into the wounds, and I think it does start to make a difference, something like maybe in a week, 10 days time, and it does make a lot of difference there. But the point is that it is not stressed as much as it's stressed in the European Western side, that the diabetes and smoking is a very, very bad combination, not just for the microvascular, but for the microvascular as well.
Amen.
Yeah.
100% correct.
Thank you.
I also never tell them that it's 21 days because they'll just start smoking right after the 21 days. So
21 days for the effect to go away.
right, and then
so they have to be
still-
zero nicotine.
But they'll still take it as like, oh, you told me I can start smoking.
Hi, so I'm Asma Ahmed. I'm also from Pakistan. So I'm from that part of the world where, whenever you see osteomyelitis, it's just like, that it needs amputation. So you kind of, spoke about a very valid point that osteomyelitis does not mean that, patient need to have a surgery or amputation. You talked about bone biopsy, but what about the radiological, modalities? Like if you can't do bone biopsy, what is the most appropriate method, to diagnose osteomyelitis? And when we put these patients on, intravenous antibiotics for a long period, how should we follow them up, with the radiological modalities, or what do you recommend?
Thank you for that question. So one of the things I didn't put in the talk, and that sounds going to sound weird, we don't know what diabetic foot osteomyelitis is. When you compare the concordance between culture, histology, X-ray, and MRI, sometimes it's a flip out of a coin. So there's no gold standard, right? But in practice, I feel like X-rays are a great start. I fear the utilization of MRIs because you get a lot of those bone edemas, early osteomyelitis, which trigger surgeries and antibiotics, and nobody knows the natural history that I know of bone edema, right? So it's complicated, and then it's a combination of probe to bone, X-ray, clinical findings. Did the ulcer heal or not heal with standard care? As far as follow-up after treatment for osteomyelitis, I personally like to get an X-ray at the end of therapy just to get a new baseline of what the bone looks like in case the ulcer opens up again. But it's also, we know ulcers recur. We don't know how many are reinfection versus, reoccurrence. And patients, and Luke is going to be the first one to tell us, these patients need lifelong follow-up for foot care, right? So it's a lifelong follow-up for these people.
Thank you.
Yeah, I will voice that. Diabetic foot doesn't heal; it only gets in remission. And so, I will make the comment. Most of the osteo in diabetic foot is chronic, like probably 80-90% of
I'm going to be a little cheeky. I don't know that anybody knows what acute or chronic osteomyelitis is.
That's exactly what I was going to say. There's no,
right.
we know that acute versus chronic is a different disease, but in terms of radiology, there's no difference in the MRI way. There's no criteria. It's exactly the same thing. There's no differentiation. That's exactly my point. So it's a huge unknown.
Thank you very much. 3 brilliant presentations, I would say. My name is Niels. I'm from Steno Diabetes Center, North Denmark. So this is easily one of the most important, perhaps the most important session at this ADA in terms of huge unmet clinical needs, immense personal sufferings from our patients, very poor outcomes, huge cost, and so on and so on. So I'd just like to comment or perhaps point to and perhaps overseen factor, the psychosocial aspects and the cognitive functions of our patients. We're doing studies into this now, and many patients with chronic foot ulcers, they are actually not able to take care of themselves. So how would you view this in terms of perspective, strategies?
Yeah, this is a very complex, multi-pronged question. Doctors are sometimes use sarcasm as a defense mechanism, okay? And so we sometimes joke that perfusion of patients' brains is the same as their feet, and when I started taking care of diabetic feet, I thought that these people are stupid. Okay, you can't be walking on your foot like this, and you say you're not walking, but I clearly see that you're walking on it. So I think these people are stupid. But then I had, as patients, university professors, and they were acting exactly the same. They're not stupid at all. They're the wisest people. They're the smartest people. So definitely not stupid. But when this diabetes is overwhelming and it's insidious, that's the problem with this. It's just the progression of it is just so slow, and when you lose the sensation, you don't know that you lose it. So it's kind of like things that you don't know, those are the things that are going to get you. So it's a very complex issue, and it's a heavy, it's an increased recognition of the STH, environment issues that are related that impact the patients, not just diabetic feet, but patients with chronic wounds as well. It's a great topic for research.
Absolutely, I couldn't agree anymore. If you will allow me just one more comment, we're looking into cognitive functional MRI imaging, doing cognitive function tests in some of these patients, and they're actually slow. They're way down on speed memory association, up to 30% of them. So we don't really know what it means yet, but we're hoping to present it next year. Thank you very much for this comprehensive presentation, I'd say, Dr. Vlad.
I'm going to throw this out because this is so interesting. One of my fellows is, suggesting there's a correlation between brain bacteria, between gut bacteria and brain, So he's like, why don't we study the microbiome of patients with diabetic foot ulcers? And so we're making they come in for us to take care of their foot. I'm going to get swabs out of the bottom. Like, how's that going to? But I think there's maybe some validity into that. So there's probably things out there that we don't know. So we need to.
Many interesting avenues to take. Absolutely. Thank you so
I
much.
just want to make one comment. You're from Denmark, and a lot of very good studies were published actually in orthopedic literature in the New England Journal on studies coming out of Denmark because of your national health system. And your country is actually very well poised to do very large-scale research on both accessibility to care and also to have so-called patient advocates that might actually be sent to their homes, et cetera, et cetera. And if you do a study like that, there's no question that's going to be a New England Journal of Medicine publication, because you can actually do that. And I think because the main subject here was compliance of patients, that's what we're actually talking about, with increased accessibility and increased advocacy, meaning people coming to your home, I think you could end up actually showing that from a financial, economic perspective, you'll come way, way ahead by those approaches. So just a thought.
Thank you very much.
Right. Hopefully it's a quick question. One more time or one more. And then we'll be sort of shuttling everyone over to the foot care interest group. So if there's additional questions, you can always ask the speakers then.
Yeah, David Ryder from Emory University. Just a quick question for the panel regarding diabetic foot infection and the use of biopsy to diagnose, and the comments that were made about a lack of an imaging marker and the cost of MRI, which is certainly very high and time-consuming. If there were an MRI marker that could diagnose foot infection, would that change things in terms of your clinical evaluation? Would that be seen as valuable, or is it still sort of a barrier from the being able to use that type of modality?
So David, I think the problem with foot osteo is a much more anterior question. Like, what is it? What is the gold standard? Because if me and you set out to write a grant about this, what is the referent, right? And I think what we need to do, and there are other surgeons in the room here who might have better ideas, is really get those bone samples, cut them very thin, and look under the microscope to see where there's inflammation, where is this bacteria, and start really understanding at a very basic level what this disease is.
10 seconds comments. I think that infection is important, but I don't think that infections are the biggest problems in diabetic foot care. Infections tend to make things a lot worse, a lot quicker, but the large majority, so we need to pay attention to that because it turns into septicemia and hospitalization, but the large majority of DFU don't heal because of infection. They heal because of loss of protective sensation. They keep on walking on the wounds.
Thank you so much. Lunchtime.